Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perceval, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide in another 2 to 4 months. So this has become a huge program within our system.
Without the Epoch device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
And good afternoon, everyone, to PerfWeb 53 and Tammy Sparacino's Journal Club 15. We're here, of course, with Tammy Sparacino. I'm Joe Basha, your humble host, and there is John Ingram coming in from Orlando. I think you'll see him here in a minute. First, I have to do all this other stuff. But John, hello. It's nice to see you again.
Hi, John.
So we're soon going to be doing something different. We're gonna, and this is John's brainchild, which is going to be Tammy Sparacino's Journal Club Casino.
Yep.
We're going to stay with the Journal Club to keep it sort of professionally themed, if you will. But at the end of these programs, and especially, I think we're going to launch it in April during our spring conference. So if you haven't seen our spring conference yet, you better check it out. Now I can't say space is limited because it's virtual. So, but you certainly want to mark your calendar and make sure that you can attend. Okay, I have to go through the housekeeping notes because if I don't, I get in trouble. Please thank our sponsors. You thank our sponsors by going to their site and telling your reps how wonderful we are, how much you love the program, and how you are so appreciative of them supporting it, LivaNova and Siemens Health and Ears. Also, thank HET. Please visit our HET.us website if you are a perfusionist or a autotransfusionist or a critical care nurse that may be interested in Ecmo specialist training. We have all of that, and you can communicate or contact us from there, learn about our company, and find out why you want to work here. Our social media, please make sure that you like, follow, and share us on the Facebook, the Twitter, the YouTube, and the LinkedIn. And make sure you give us a thumbs up. No one is allowed to give thumbs down. In fact, I think that feature is actually blocked. And also, what else? They have to subscribe. That's it. Subscribe, please, 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 please. That's so important to us. And I'll tell you what, our subscribers on YouTube, our membership in our perfusion education library, our Facebook followers, Twitter followers, and all of that stuff, there is no doubt we are absolutely number one as far as providing high quality, relevant, professional level perfusion education, and really nursing education and physician education and ECMO specialist education, because we are not really just pigeonholed, if you will, in as only perfusion education. We are perfusionists, and we certainly want to certainly support our profession, but this does take a team, and we're learning that more and more, which I'll talk a little bit about when it comes to the what we just experienced over the last year with the COVID and stuff. Website and contact information, so you can reach out to us at perfweb.us and perfusioneducation.com. If you can, perfweb.us is really our schedule. Perfusioneducation.com is our library. But you can reach us from either of those locations if you have a topic you would like to suggest we discuss or find a content expert for. If you'd like to join our faculty, if you just have a question or a comment, please feel free to do that. And you can even do testimonials for us up there, which is really helpful and beneficial. And we would appreciate that a tremendous amount as well. Remember, our programming is free. And a lot of places don't do this, but all of our program is free for people to watch and learn. You only pay if you need a CEU certificate, and I think that is extremely unique in the education world. But I am philosophically an open source person and believe information that is helpful to patient care should be openly shared. That's just my viewpoint. Now, if you need the CEU certificate, yeah, I don't have a problem charging for that because that costs us money to produce that. It costs us money to produce this. But, you know, at the end of the day, information should be shared. We have a call-in number. When we do the Tammy Sparacino Journal Club Casino, you will have an opportunity to spin a wheel that will have various prizes. This is, again, this is John Ingram's brainchild. You have to thank John when he comes online. I'm thanking him now. Brilliant idea, and there'll be some really cool prizes, and that's how we're going to reward people for calling in. So call in, please. Would love for somebody to call in today, in fact. Call in, be a part of the conversation. You don't have to ask a question. Just have a comment. It doesn't make any difference. Just be a part of this community. And then the podcast, I think that's next. You can find us on your favorite podcast provider. In this particular case, I think it's Podbean, but you can find us on iTunes. You can find us on, what other ones? What else is there? Spotify, all that stuff. I don't know a whole lot about those things, but all of these programs are essentially podcasted with the voice, so that if you're driving in your car and you want to listen, you can certainly do that. And then our new MediWeb app, I do want to talk about that, but I'm not going to talk about it today. I'm going to switch gears, and I'm going to actually show you how this app works and all the things that it can do. So if we can switch to camera 2, I'm going to let Tammy do some talking while I go over there and actually show people how this app actually works.
Okay.
Thanks.
Sounds good.
Nice to see you, Tammy.
Nice to see you.
Nice to see you someplace besides the hospital.
It is nice
And I
to
think
see you.
you're on camera 2. Are you still on camera 1 or camera 2?
Oh, hey,
Oh,
John.
okay, John's on camera 2, so you're on camera 1.
Hi, John. How are you? Is he with
Hey
us?
guys,
Oh,
good evening. How's everyone?
good. Joe is so excited with the new toy that we have, so we got to let him get set up so he can show us all about this new app. How's everything going in Orlando?
Oh, everything's going great. It's status quo. Ecmo craziness. I wish the success was higher, as it was back about 8-9 months ago, but for some reason we carry on. And I wanted to circle back to what Joe was just saying about people calling in. It reminded me of a saying that I've used many, many times when I either was teaching students or had new hires and they were, about to ask a question. You ever hear people preface a question by saying, this might be a dumb question, but, and I always stop them and say, listen, there's no dumb questions, only dumb answers.
That's
So,
right.
so fire away. So
Very,
people
very
who are
true.
listening, don't be shy about calling in and being part of the conversation. Just remember, there's no dumb questions. We're full of dumb answers, so the onus is on us to try to make the conversation worthwhile. But the onus is not on the caller to try to impress or anything. So I hope people keep that in mind if they consider calling in.
Yeah, feel comfortable calling because we're
Yeah.
all in the same game together. We're here to teach each other and to learn from each other as well.
Agreed.
So can we go to this camera and show the app? There it is. Great. Okay.
All right.
So where'd it go? Oh, there it is. Okay. So I wanted to just, before I do that, let me show you it. So here it is, and there's a critical care perfusion app, which is here. You can get it on YouTube. You can get it on, not YouTube, the Apple Store, the Google Play Store, all that, the iTunes, whatever. But there's two different apps. There's that one, and there's a medication app here. But this has both in it, and this one's 99 cents, and it just does IV rates, and it's really good for nurses. If you have a nurse as either a husband or a wife or a girlfriend or a boyfriend or whatever the case may be that's working in the ICU, that app is very useful. But I want to show my perfusion colleagues and ECMO specialists this one. I'm only going to go through it very quickly. Is it focused good?
Yeah,
Is
looks like it.
focused good? It is?
Mhm.
It looks kind of crummy to me, so I want it to be focused really good. I think, how does, tell me.
Wait, stop. Let it go. I think that's pretty good.
That's pretty good, okay.
Yeah.
Yeah, that looks a little better. So we're going to hit perfusion. So we have at the very top, you can see all the various things we have. Okay, so there's a whole bunch of things, nomograms, everything's included in this. And one of the things I like the most, and I'm going to show you the perfusion quick calcs, but let's say you're transporting an Ecmo patient, John, and you go over here, you have an E cylinder, and you say to yourself, you know what, do I have enough in this tank to do this transfer? And there's 650 PSI. And you say to yourself, okay, how long is that going to last me? I'm running it at 4 liters a minute. Can I make this trip? Well, you have 56.45 minutes. Gives you that information right off the bat. So if it's a 20-minute trip, you know, you've got essentially more than double that time. So you may not need to, I probably would change the tank anyway, but if you're going on a long trip and you have 1,000, 1,500 PSI, it can tell you exactly how long that is. So we're going to do the perfusion quick calcs. We're going to say it's a man, so it's already picked, and it's going to calculate the blood volume at 75 cc's per kilo. You're going to put the age of the patient in. So in this case, we're going to say that they're 67 years old. We're going to get a pre-op hematocrit of, let's say it's 38. We're going to say he is, we'll do it in inches, we'll say he's 5'10", 70 inches. We're going to put his weight in as in pounds. For the sake of this argument today, we're going to say it's 206. We're going to put a pump prime of, total pump prime we'll say is 1,000 cc's. We'll say the anesthesia volume, since they usually give a lot, is 1,600. We'll say that his pre-pump urine was 500. And we're going to use 300 or 400 units per kilogram for our heparin dose. I'll just go ahead and put 300 for now and hit calculate. And you scroll down, oh, shoot, sorry. And it gives you a BSA, a BMI, your estimated blood volume, your red cell volume, your heparin dose in units, your estimated on-pump hematocrit, protamine dose based on that heparin dose. And you have to, of course, take that at a grain of salt because it depends on how long the case is, how much more heparin you had to give, whether they had sensitivity or AT3 deficiency, whatever. But it also gives you all of your indexes from 1.6 all the way to 3.0. So all of this is calculated for you based on the information that you input. And I think that this is, you know, for me, this tool does everything. You can have also Ecmo if you want to know what your, let's just say your Murray acute lung score, what it is. You can look at your chest x-ray and say that you have 3 quadrants are consolidated, your PaO2, FiO2, or your PF ratio, whichever you want to call it, is, let's say, 100 to 174. Your PEEP is currently at 10. And your compliance, all of this kind of thing, you can put in there that usually, let's say, it's between 20 and 39, so not horrible, but not great. And here's your result. It gives you your score. It's severe, not eligible for Ecmo based on this criteria. So this criteria actually gives you a lot of very good information, including when you should or shouldn't use Ecmo based on objective criteria. So he was actually not sick enough for Ecmo, which was the reason that was that came out not eligible for Ecmo at that time. But that's a clinical judgment call. But that gives you an idea of all the things it does. It has hemodynamics. You can see all of those there. It has your, forgive me, it has clinical calculators. What's your, let's, for example, what is your allowable blood loss? And this is based on hematocrit of when it will get to 21. We'll say the patient weighs 87 kilograms. Their starting hematocrit is 40. And it will tell you that you can lose 3,099 or 3,100 cc's of blood replaced with crystalloid, non-heme, and that is your allowable blood loss to where you reach a hematocrit of 21. So it is predicated on that number. And then you can always reset it and so forth. So there's the app. I hope you all will take a look at it. I just wanted to show it to y'all. Instead of doing it like I normally do and just showing some static images, show them actually what it looked like. And I think it's a really cool tool to use for perfusion, for nurses, for Ecmo specialists, for NPs. It's good for physicians, I think. It has a lot of really neat stuff in it. So take a look at it. It's $2.99. I only need to sell 1 million of them. And they can only be sold one at a time unless you have a family and you want to do a group rate. I'll think of something if you got 100 or more. About 1 million of them, and I get to retire. So if you could help me out and buy them, it'd be great. But also look at the other thing too, the medication app, because that's 99 cents. It's in there as well, but just the pure medication app is only 99 cents. And actually, they're selling pretty well, so I'm pretty happy with that. It was very expensive to design, very expensive to be created. Nothing is ever for free. And so the 1 million that I sell, if I sold them all at $2.99, I'm not going to get all of that money because it was very expensive to make that app. But it'll be enough, okay? I'm getting old and I don't have that many more years to spend a lot of money. So there's all my opening remarks. That was a whole lot. But John, you brought something up that I wanted to talk about.
Yep.
And that is that I've been, and I don't say this in a braggadocious way. I say this, just because it's a fact. But I have over 4 decades of doing this job. And I will tell you that this past 8 weeks has been the most challenging, stressful, and to some degree, based on what you said, which is our experience as well, demoralizing 7 to 8 weeks of my career. The amount of death that we have seen despite every effort and every level of technology that we've had. With this first round, we had about 40 to 50% survival for COVID ARDS. This second round has been 0. And I'm demoralized by it.
Possibly one today.
Possibly one today off ECMO. Hasn't survived. That's true. So we may have one.
We may have
which
one.
is unfortunately a sad commentary.
Very
Now,
sad.
the ones that got lung transplants that we got transferred out, they may have had a shot. So, but those are very rare because lung transplants are so incredibly selective. It's such a precious organ and so limited in supply that you have to have the perfect candidate before they will consider doing a lung transplant. John, what do you think? And Tammy, what do you think? What do you think?
Well,
what's your
let me
experience?
chime in. You said they're off ECMO. Okay, they're off ECMO. In what state and now what?
No, we have one patient that we just weaned from ECMO today who is still on the vent. His lungs do appear improved. He's the only one of the patients. So I have somewhat of a theory, and I'll tell you my theory, and you guys can discuss it and tell me what you think. But the first wave that we got, it was a very novel disease. We didn't have that many of them. It seemed like a lot, but it was not overwhelming the system. And everyone got treated very rapidly. So from the time they came into the hospital, given the antivirals, the remdesivir, given if they had them, the monoclonal antibodies, like the Regeneron, they weren't giving them steroids at the time because they believed steroids was the worst thing to give them, right? Now it's the opposite. But they went from in the hospital, high flow oxygen, BiPAP, ventilator, ECMO, all within 3 or 4 days. They spent very little time in an oxygen deficit environment physiologically, or straining to breathe, stressed. The second wave, we were so incredibly overwhelmed. Everything was done to keep the patient out of the hospital. Then, once they got admitted, everything was done to keep them on the COVID unit with just oxygen and high flow oxygen or whatever. It wasn't until they either failed that, they were on BiPAP, coming to the ICU, high risk of intubation, that they eventually become intubated. Then they're 7 to 14 days of that before somebody finally says, we're failing at this, that we can't continue, we have to put this patient on ECMO. And it's a limitation of essentially resources. And these are community hospitals. So we're doing extraordinary things in hospitals that are not really designed as high volume ECMO centers. Now, we're very good at doing ECMO, but we had at one time in our little community hospital trilogy, if you will, the 3 major hospitals, 11 ECMOs going, which at one time, which is, of course, much less than you have at your center, but more than they have at Methodist in the medical center, Texas Medical Center, a huge medical center. And so for us, this was extraordinary because they were so full, they couldn't take, they were diverting to us.
We were getting diversions.
Yes. We were getting
in the
diversions.
community hospitals.
Community hospitals and from the medical center. But we were getting from other community hospitals that don't even have ECMO capability.
What I meant was we were community hospitals and the medical center was diverting to us.
Yes, absolutely. Yes, 100% true.
Yeah, guys, that was going to be my comment. In the early days, we took on, an aggressive stance to take these people, and at some point we had to push back. We being any big center that became with a lot of ECMOs. And let me tell you, 11 ECMOs is no small shake. That is a lot of people on ECMO, even if it is spread out among 3 hospitals, because it's probably 3 relatively, decent but not terribly huge community hospitals you're probably talking about, which is a big deal for a community hospital to have 3 or 4 ECMOs. But we had gotten to the point where people were calling us, as you said, Joe, with patients that had come down the line a lot longer, a lot slower, and we would have to say, no, we can't take them. You're going to have to keep them.
Yeah.
And so I think that people are being cared for at some of these hospitals that never really intended to have such an intensive ECMO program or an ECMO program at all.
Mm-hmm.
Yes, exactly.
That doesn't probably explain why our particular hospital and your particular major hospital are having such a lower percentage of survival. But overall, we really tell people no an awful lot because we just do not have the space to take anybody else.
Yes, but John, and Tammy, so my theory, and this is my theory, it's untested, it's certainly unproven, but I think the first wave, because we treated them so quickly and we had better outcomes, is because in the second wave, we have had such demoralizing outcomes, is that they have lived in this very long-term low oxygen state and enormous stress, releasing all kinds of inflammatory mediators, which I think affected the lung tissue way more than the disease process itself. It was this systemic inflammatory response that was perhaps more targeted to the lungs, I'm not sure, but they also went into renal failure. They also had hepatic failure. We saw multi-organ failure just becoming and I think that was from long-term oxygen debt environment plus all of the stress, the inflammatory stress mediators that are associated to it. Now that's my theory, but again, it's untested. It'll be very interesting to see if data comes out about this. We had one patient where his lungs essentially just kept blowing up, and we clipped them. We did biopsies. We had to do partial lobectomies, then full lobectomies, then double lobectomies on the right side with a partial on the lower lobe, a partial lobectomy on the left side. And I actually got a chance to look at the lung tissue because they sent it to pathology for fixed. And it looked like a piece of different color, but like a piece of that, what's that stuff that guy uses to seal stuff? Flex Seal. It looked like a piece of Flex Seal, but it felt like soft, but then like concrete. It was a very weird piece of tissue because the lungs are such a beautiful organ, and these lungs looked horrible. They just didn't look like lungs. Very, very, very strange disease. And we'd fix the holes, take him back to the ICU, and then he wouldn't have the air leak, but he'd blow a hole out somewhere else.
Yeah.
And it just kept happening. Yeah.
Well,
and he was 57 years old.
Nope. 47.
47 years old. I'm sorry, 47 years old. Yeah, thank you.
You know, they're all young. The reason they're all young is that we're not putting anybody on ECMO if you're 59 years old and 355 days. If you're past that, you're probably not getting ECMO because we're reserving it for the 30s, 40s, 50s crowd, and you get upper 50s and you're pushing it. So all the patients are young, which is demoralizing. And then the lungs, you see, I think we were putting people on ECMO as they were going downhill. Now we put them on ECMO when they're already at the bottom of the hill, and the ventilator and everything else is absolutely not going to work, and we have to put on that ECMO or they're going to die.
Yeah, because there's not, there's, you know, people I don't think really appreciate how few hospitals actually do ECMO.
Yeah.
But then on the other hand, you don't want every hospital doing ECMO because it is so incredibly, you know, it's not like doing hemodialysis. Not that hemodialysis is not as important. I'm not implying that, and I don't mean anything negative. But it's far more complex than that.
There are a lot more moving parts and
resource utilization.
Right. I mean, it just depletes your resources, people resources, your actual physical resources, and it requires your nursing staffing that you need for those.
And intensivists and perfusionists.
Exactly.
And every hospital can't have that. And I'm very concerned, I don't mean to interrupt you, but I am very concerned that some people are trying to push a narrative of we need to make this very simple ECMO system that you can just put it in and anybody can run it. It can just essentially run itself. And every hospital wanting to clamor to adopt ECMO technology into their tool chest. And I mean, I think that's going to be far more destructive, to be honest with you. I'm very frightened and concerned that may be something that I see happen in my lifetime, which I think would be a horrible mistake.
I think it will happen. I mean, we already know systems out there that are marketed that way, and
companies have no scruples.
Well, some do, but I mean, it sounds like a good idea, but in practice, it's not going to be that easy. And we've seen devices like this come and go where they're going to be automated and you're not going to need extra staff for them, whether that be perfusionist or 2 nurses to 1 patient or whatever. And most of those go by the wayside because there are negative effects and people are, don't have the kind of response they're going to have, or patients are harmed, and then they kind of just disappear.
And ECMO should be a more selective process. You have to be very careful who you put on.
The problem is not that the ECMO equipment is in any way failing. The problem is the consequences of putting somebody on ECMO. So you can come up with a simpler device with less knobs and buttons like someone has come up with. The complications and the intensive hour-to-hour, shift-to-shift things that you're going to have to do to get this patient through is going to have very little to do with the fact that the equipment may fail. I mean, we do see failures, but I think that's probably less than 1% of our problem.
Sure.
And, this is so let's compare it to dialysis for a minute. Dialysis is very intense. It requires somebody who knows a lot about what they're doing. But regular dialysis, Joe, not CRT like in the hospital, but let's just say regular dialysis, people go to for an hour or 2, 3 times a week, something like that, right?
4 hours.
Yeah.
3 or 4 hours.
This is 24/7 for weeks and months at a time. You have to have critical care docs around the clock. Every shift has to be covered. Nobody can work 7 days a week. You have to have the skill of all your multiple disciplinaries around the clock. And this is like you turn on the lights and you never turn the lights off. It's kind of like having a 24-hour open, store or business that you run. It never goes on vacation. It never gives a break.
No.
And this is the downfall of somebody who thinks you're just going to buy an easy-to-run piece of equipment and bingo, we have ECMO. Your problems have just started.
You'll do an in-service, and everyone will be experts at the in-service. And I think that you just brought up a very good point. I do want to make this point. ECMO is not curative.
Well, that's what I was just going to say. John, you were talking about having a 24-hour store with the open sign on, and even stores have an end time. They know we're going to get to close or you know, whatever. There's no end time with the ECMO because it's not like dialysis where you know it's 4 hours today. It's could be, you know, an undetermined amount of time, and often is. We don't know if it's 10 days or 6 weeks.
And they bleed. And they have secondary, or
well,
they have
ECMO is just the beginning of all of the things that are going to are going to happen.
And you have transfusion needs, and you destroy your blood bank's ability to provide you with products, and now you have a grossly anemic, thrombocytopenic patient on ECMO, and you need blood and platelets, and you can't get them.
Well, besides, I mean, that's.
I wish it was that easy. I wish it was, but it's not curative. Too. It's a bridge to recovery, a bridge to a permanent device, or a bridge to a transplant. It's not for VA ECMO, for circulatory support, totally different animal.
Yeah.
For pulmonary failure, it's either a bridge to recovery or it's a bridge to transplant. And there are very, very, very few available lungs to be transplanted. And so it's more than likely 98% of the time, if not more, because you have to be an ideal candidate to get a lung transplant. It is a bridge to recovery. And if you have an unrecoverable disease, you now have a patient on ECMO, and we are very good at keeping people technically alive. Our technology and our skills and our knowledge and ability and medicines have made it incredibly easy for us to keep an unrecoverable patient alive. And that's, I think, that is our Achilles heel, I believe. I have a question from Karma Police. I don't know who Karma Police is, but hopefully they won't come arrest me, or if you could, just give me a little bit of better karma if you don't mind. Did you guys have any help with nurses trained in ECMO? So we did not, but it is something that I think about. John, you have a different experience. Why don't we listen to your experience there, and then Tammy, maybe you could talk about what we view as probably a necessary thing we're going to have to do to move forward with this.
Absolutely.
Well, it sounds, correct me if I'm wrong, sounds like the questioner is asking, have you been able to take some of your nursing staff and sort of teach them a little bit about the ECMO machines?
No, I don't think that's the question. I think he's asking is, do you have nurses that are trained in ECMO?
Like
in other words, ECMO specialists.
Yeah.
Well, yeah, we are a huge ECMO specialist center, but that is actually very unusual. It's difficult, very difficult, to have an ECMO specialist team, because you have to have, it's a long story, you have to have all year round pretty close ECMOs going on so you can maintain their skills and maintain their hours, by the way, because if you all of a sudden, if you're only going to do 5 or 6 ECMOs a year, it's almost impossible to have an ECMO team, because you can't keep their hours up. They have to have a second job as a respiratory therapist or a nurse or whatever. And then when ECMO comes up, now they have to work shifts as an ECMO specialist, and now they're getting overtime usually. The hospital doesn't want that. And it's been 6 weeks since you had the last one. Their skill set is not being maintained. And so, you know, I think I see this in my travels that people are like, well, we want to get, you know, some ECMO specialists to help us out. Well, we're only on our third ECMO, it's the third one we've ever done. You know, it's just never, it's not going to happen. You're not going to maintain a skill set that way.
Right. That's not a realistic solution for places that want that for a very small ECMO program. You have to be a very experienced program that has the numbers to be able to support that.
Mm-hmm. So how do you feel, though? You know my philosophy, you know how I feel, and I think we have the numbers to support it. Notwithstanding, I think John's point is very well taken, and I agree with him 1,000% if you can do that. But you know my philosophy about where I think we need to go in places that have an established ECMO population, that we would have enough patients to where we could actually employ people that is what they do.
Yeah.
So I'll let you take it from there.
Well, I think considering John's point, you have to have established ECMO programs, and we really need support staff. There's not enough perfusionists. I mean, as we saw, surgeries might slow down a little bit, say in a emergency situation like this pandemic, but they didn't stop completely.
No.
We had lots of heart surgeries going on.
And mostly emergencies.
And they were a lot of emergencies, and it's very difficult to staff those kinds of things because, like John has mentioned several times, you get one off and you think, oh, we're going to have a little reprieve at this one location or whatever, and no sooner than you get the machine cleaned, you get the phone call, we have another consult, and we're putting somebody on Ecmo.
Correct. Yes, absolutely.
So,
and it's easier if you're at one institution versus 4 or 5 institutions or 3 or 4 institutions. That makes it a whole lot harder to do. But I do believe that the nurse, and I do think respiratory therapists are great. John, I don't know how you feel about this, but I tend to lean more towards nursing only because I think they have a better appreciation for the patient milieu, if you will. They understand the fluid balance, they understand renal, they understand, liver, they understand all the stuff that you have to take into consideration. You have a call, I'll be right there. And so I think nurse ECMO specialists, in my view, are perhaps better equipped, but from a technical perspective, I think respiratory therapists can do it and they can learn it. Mm-hmm. But a critical care nurse just knows so much more about managing the patient, transfusion management, all of that kind of stuff. But I do think that it's going to be something we need to do. I do have another question, and it is from, a call in. Okay, go ahead.
Hi, Meg Gray speaking.
Hey, who is this? I'm sorry.
Hi, it's Meg Gray speaking.
Hey, Meg.
Hi. Did you have a question?
How are you?
We're doing great.
Great. Thank you for calling in.
Yeah, you're calling. I think you're calling from our own studio. So what's going on? How can we help you?
Well, I'm just wondering about the preferred cannulation for COVID ECMO patients.
Great question. Why don't you field this one?
Well, our preferred cannulation is in the IJ. We use the Avalon cannula, and we like it a lot. And of course, it's like all dual cannulas that go in the IJ. It's positional, but we feel that it is, once positioned correctly, most of the time will stay in a good position if it's cared for in a way that it should be when you're moving the patient. You have to, of course, have surgeons who are skilled at the insertion, and I just think it's a really good device.
I think Avalon or Crescent are both great.
Medtronic Crescent, yes.
I think double lumen in the right IJ is critically important so that you can turn and move the patient, sit the patient up. You also reduce your infection risk by staying out of the groin. The groin is a dirty area, but it also makes it very difficult to sit these people up if you get to that point. Of course, if you're talking about a lung transplant candidate that is chronic versus acute, there is a big difference, but still both require, I think, the same cannulation. At the end of the day, I think if you use ECMO, I think you have to have the ability to get portable chest x-rays, people that know how to read them, see about the cannula placement, know how to put them in, and also I'd like to just very quickly say that transonic
I was just leading into that.
ELSA meter, I have really come to believe that that is an essential device. I'm going to do a big talk on this because it identified a cannula malposition secondary to the patient losing weight and the cannula popping out of the IVC and going into the RV. And that was, we were like, what's happening? Why are the SATs not as good as they were? Did a recirc, it went from less than 5% to over 40%. Did an immediate chest x-ray, found the cannula had malpositioned.
But
so
it's
very
also
important.
And it's also important to mention on that particular situation, the cannula markings had not moved.
Correct. They had not moved.
The patient was just on CRRT, had been in the hospital a while.
Long time. Had lost a ton of weight.
Lost lots of weight, got all the fluid off, and basically looked like a different person. And of course,
and they had strange anatomy too, because the surgeon who put the cannula in said that the IVC came off on more of an acute angle than what he's used to seeing. So we had some weird anatomy going on anyway.
But we originally had it in the right spot.
Well, for weeks,
Yeah.
for a couple of weeks.
And we tested it with the transonic, less than 5%, and the SATs were really good.
Mm-hmm.
And then just changed. So then, of course, you go through well, let's move the SAT, the arterial SAT monitor.
The pulse ox.
Yeah, the pulse ox. Thank you. And then
Draw a gas.
Right, draw a gas, and we just could not figure it out.
Mm-hmm.
And then, of course, that makes perfect sense.
Yes, it was very, very helpful. John, what do you think about that cannulation? Because I have two other questions, and then we actually have to do the journal club. So,
Yeah.
you bring that.
Thank
You
you,
talk
Meg.
about thank you, Meg. You bring that question. You know, you can always come back here. I know you're in the other room over
She's
there.
in the green room.
If you're in the green room, you can always come back here. But thank you for calling. And we do have two other questions. But talk about your cannulation. I know you use the Avalon and the Crescent a lot.
Yes, so I think the best way to answer this is no wrong or right way necessarily. We started off with right IJ and right fem on everybody, but that was for a different reason. Because we were doing it, trying to do a bedside, and we didn't have all the fluoro and stuff, and we figured we could do that easier. Because if you're going to do Avalon or Crescent, you really have to have fluoro and see exactly what you're doing. So whatever it is you feel you're good at, it'd be my suggestion. If you feel that you're good at and you're proficient at putting in the Crescent, go with that and stay with that and get good at it and get fast at it. If you feel that for some reason right IJ, right fem is your thing to do that. Most of these patients with COVID this sick are not going to be ambulating anytime soon.
Mm-hmm.
But regardless, it is a thought for anybody that you could ambulate down the road that you would want it out of the groin. So I would say, there's no COVID magical perfect cannulation. Do the one that you're comfortable with. And I want to say something about what you just said about the cannula moving. Don't be fooled by the fact that it hasn't moved on the skin. In other words, you can see the markings are the same place you sewed it in. Does not necessarily mean that the cannula has not moved inside the patient. I know that sounds illogical, but it does happen and it will happen. So if you have suspicion of it, take an x-ray, whatever you have to do to see the position of the cannula. The fact that it's still sewn in exactly how it was, it's strange to think about, but things change internally. Things turn and different things like that with moving other patients. So,
Yeah.
So this next question, we have two questions, and then we're going to go to the journal club. Question for you: have you experienced any difference in patient outcomes in your hospital, which are being looked after by Ecmo specialists versus perfusionists?
well, our outcomes were very, very high very good for a long time. They've gone down now, but I think that's happened nationwide. Well, our Ecmo specialists are, first of all, intensely trained, highly qualified ICU nurses, and the respiratory therapists that we have are very highly trained and highly skilled also. And in addition to that, we have full-time perfusionists in-house just for Ecmo, and that perfusionist cannot be running a case or be tied up doing anything else. So that if there's anything in the least bit off the beaten path, perfusion is present. Most of our Ecmo specialists can handle almost any situation without us having to put hands on, but sometimes we do. So we have a very intense Ecmo specialist program, both in training and experience. So I would say our experience is probably different than most, and our skills are probably different than most, and our success is probably higher than most. But it's all because we'll do close to 200 plus ECMOs this year, probably.
Mm-hmm.
Yeah.
That's a lot.
That
And
is
so,
a
but
lot.
you have a blended program, which I'm
Mhm.
also very supportive of. I really believe that that perfusionists, by virtue of our training and what we do every day for a living, we are extracorporeal circulation, whether it be systemic arterial or whether it be pulmonary experts. That is what we do. We're plumbers, essentially, blood plumbers, and we're really good at it. So I do think blended programs are the best way to go. Question for you, speaking about organ shortages, do we, or John, you can weigh in, of course, as well, transplant lungs or hearts infected with hepatitis C virus, Hep C? They started doing that recently where I was trained as a perfusionist, and it seems they have good outcomes. So I know they have a pretty good treatment for Hep C that's available now. So we don't do transplants,
have any
so I
experience
can't
with
really
that.
answer it.
Yeah.
But John, what do you think? You hear of anything about this? I mean, I would think it would make sense. It would certainly increase the donor pool.
Yeah, availability.
But to what degree, I don't know. So good question, Amit. I can't necessarily answer it. John, can you?
No, I think we could research that and get back to him with a better answer. I'd be speculating.
Okay, fair enough. So, okay, this has been a very interesting conversation. This great opening remarks. They lasted a little longer than I thought they would. But I think we're going to move right into Tammy Sparacino's Journal Club number 15, and it's about, I think, something about cardioplegia, myocardial protection being a process, not just an event.
Correct. Okay, so we did something a little interesting with our article selection this week, or this month. We went with a commentary on a topic that I find very interesting because we really don't have an answer to what the overall question is. But this commentary was posted in the Journal of Thoracic and Cardiovascular Surgery. It's a commentary titled Myocardial Protection is a Process, Not an Event. And you can see it was a commentary put together by two docs, Dr. Langer and Dr. Valhakis. I'm sorry if that's incorrect. They're from the Department of Surgery at Harvard Medical School.
We ought to just say sometimes Dr. V.
Okay, that too. In Boston, Massachusetts. And it was written in September 23rd, 2019 is what it says. But it's actually about an article they're referencing that's about to be published this month. Okay. So here, they don't really have an abstract because of the nature of the article is a commentary, but here it just tells you kind of their opening remarks. The study by Timmick and colleagues in this issue of the journal is the most recent addition to literature on myocardial protection in adult patients. Dr. Pedro Del Nido's cardioplegia formulation has made a major contribution to pediatric cardiac surgery. Because of this success, it continues to gain a greater and greater foothold in adult cardiac surgery. However, its broad adoption remains controversial. The current publication of Timmick and colleagues is another contribution supporting its application, but it must be interpreted with certain caveats. Okay, so the reason this paper or commentary was written and why it's being published is because they're looking at, you know, why the Del Nido is gaining such popularity in adult populations when actually there have been quite a few studies, but all the research that I did, which incidentally, if you Google Del Nido cardioplegia use in adults, almost 8,000 scholarly articles come up. So wow. There's a lot of things. If you narrow it down to just something that also says 2020, so the most recent ones, still almost 5,000. And that's because a lot of people are very interested in this topic. And we're going to kind of get into why it's so desirable. Okay. So the problem to be solved here was just looking at whether or not this particular article that they're referencing, which we'll get to a little bit later, even though it hasn't come out yet, I do have the abstract and the results from it, why they were looking at, were their conclusions valid? Could they be applied? Is it actually a good idea for adult surgery? How did they do it? Well, the commentary looked at this particular article, and this one actually came out in December 2020. I have another one that hasn't been released yet we're going to get to in just a minute. But this was also published in the Journal of Thoracic and Cardiovascular Surgery, and you can see the titles, Del Nido, Cardioplegia, and Isolated Adult Coronary Artery Bypass Surgery.
And that's Timmick, that's the one they referred to.
Yeah, Timmick, this is the one they're referring to. The commentary is written about this article, okay? And they give you a little background that, in case you don't know, Del Nido is a cardioplegia solution that offers a prolonged single-dose myocardial protection that was first used in pediatric cardiac surgery. Timmick set out to evaluate the efficacy of Del Nido cardioplegia, which is going to be abbreviated DC, in adult patients undergoing isolated bypass surgery. They looked at January from 2012 to October of 2017. It included 851 consecutive isolated cabbages that were performed by 2 study surgeons at their center, comparing blood cardioplegia to del nido, and then they propensity matched and yielded 325 well-matched pairs. Okay, here's the results. So the results were about 83% of the patients receiving del nido in the propensity matched groups. The median, they go through the T levels as well as some various other things, but really what I'm trying to...
Indicators of myocardial injury.
Right, and so they're looking at a lot of different things to see, did they actually provide the protection, okay? And then they get into the specifics of their patients. But here's what I really wanted to get to was their conclusion was that it revealed that there is non-inferior myocardial protection in clinical outcomes with del nido versus blood cardioplegia. They're both routine.
In both
routine and greater risk patients undergoing the isolated cabbage. The del nido demonstrated the feasibility of a single dose administration, and what they recommended was that larger randomized studies need to be completed to further study the safety and efficacy when you have longer cross-clamp times. Okay, so that's the article that the commentary was about. Here is a summary graph that talks, just goes through everything that I told you, but it's kind of put in a way that's real easy to just skim over. And the end result was they found del nido to be safe and effective.
Can I ask you a question about this diagram?
Yeah.
I noticed that in the del nido, the diagram on the top left, they have the retrograde X'd out. So is that, in this article, did they give both antegrade and retrograde cardioplegia with the blood cardioplegia on the right, but
Correct.
only antegrade on the del nido?
Yes.
Huh. And now, see, that concerns me. We'll talk about that.
Yeah, we'll talk about that a little bit later. Okay. So our author's conclusions from the commentary. So they said that the study is further evidence that single dose is safe for revascularization operations with cross-clamp times that were included in this study. So again, we're not talking about long cross-clamp times. However, what they said was that we acknowledge that they don't address the major remaining question, which is what do we do to protect hearts in extended periods of time? So until that question is answered, the debate will continue. So all in all, this commentary thought it was a good study, but it didn't really answer any question that the other studies, it didn't answer a different question that other studies that are out there that have said del nido is safe for adults. But what do you do when you go past the recommended time? Okay?
Yes, that's a really good question.
That's the question, right? So I have actually a couple other commentaries that are also about del nido usage that I wanted to get into that are a part of what we're going to talk about for our focus topic. So do you want to hold panel discussion until we get through these?
Yeah.
Okay.
I think that's a good idea.
Okay, so here's what we're going to talk about. Is del nido a good choice? Continuing our discussion for the use of del nido for adults. Okay, let's just go through a little quick review. So we know cardioplegia technique has a lot of variability. There's various solutions that you can use, blood, crystalloid, various ratios.
Microplege.
Right, crystalloid only. How's your delivery? Are you going to single dose, timed multi-dose, continuous dose? How much volume are you going to give on all of those? What's the location? Antegrade, retrograde, coronary ostia, bypass grafts, temperature. Are you going to do cold induction, warm induction, mixed cold and warm? Are you going to do a hot shot? Okay, so there's a lot of different things.
There's a lot to unwrap there.
There is, a lot. And then there's the different cardioplegia solutions. So we've got single dose things, the HTH custodial, the del nido, multi-dose. Are you going to do crystalloid only like St. Thomas? Are you going to do blood cardioplegia? Do the most common Buckbird 4-to-1 on cold delivery? Are you going to do microplegia? Are you going to do the Califior, which is warm delivery? Okay. So now that we've kind of got all of those things in our mind, let's talk about this next commentary. So this is actually published as well in the Journal of Thoracic and Cardiovascular Surgery. And this one was written just a little bit after that first commentary, so about a month after. It written by Jennifer S. Lawton. She is in the Department of Surgery at Johns Hopkins in Baltimore. And here are her thoughts on this. Okay, so this is kind of long. This is just her intro, but really what I wanted to get to was she talked about that they suggest, she's going to be talking about Timmick's study as well. Okay, and so she said that they propensity matched 325 patients who received Del Nido versus blood cardioplegia. They suggested that they needed to place a retrograde cardioplegia catheter to redose cardioplegia and to manage glucose were cumbersome. So they were talking about in the blood cardioplegia, having to put that retrograde in and then managing glucose made it difficult. They noted no difference in survival probability at 4 years. However, only 24 of their patients that received Del Nido were even in the group at 4 years. Okay, that there was, let's see, what else? The bypass and cross-clamp times were longer in the blood cardioplegia group. However, which I think the indication was that that's because they had to stop and redose, so they had to stop their, their sewing that they were doing. But she notes that more bypass grafts were performed in the blood cardioplegia group, so that could also account for increased times. The limitations she found on the study were cardioplegia methods were dependent on which surgeon and what his preference was. They varied within the groups. The systemic temperature varied. The cardioplegia strategies were different during different time frames. Information regarding completeness of revascularization was lacking, and very small patient numbers were in a subgroup. Okay, and I thought this was, she included this graphic, and I thought it was great. So cardioplegia, we got to proceed with caution with what we're doing here. Okay. This was her general summation at the end of her commentary was that Timmick and colleagues noticed that the use of Del Nido enhanced the flow of the procedure by eliminating undue interruptions, facilitating a tidy operative field while permitting expeditious performance of the planned procedure. Widespread adoption that is driven by a surgeon's convenience may not be appropriate for all patients. Single-dose antegrade cardioplegia may be easier but may not be better. The jury is still out, and surgeons should proceed with caution until larger randomized trials, including high-risk adult patients, document superior myocardial protection with the Del Nido. Okay.
That was very good. In fact, I think that was probably, in fact, the comments that I'm getting over here on YouTube, I'm about to read them to you after when we're ready.
Yeah.
But this is a very good topic.
Yeah, I really enjoyed researching it, and I loved getting the opinions of. I don't normally go with strictly commentaries, but they were so good, and they all had their different perspectives on why we're really kind of jumping the gun that Del Nido is.
That's what I'm getting on this, is a lot of reservations.
Yeah. Okay.
And I'll talk to you about that.
Okay, we're going to talk about that. I've got one more commentary.
Please.
Also in the Journal of Thoracic Cardiovascular Surgery. This one actually just came out, so it was published this month. And the title is The Role of Del Nido Cardioplegia in Adult Cardiac Surgery. The jury is still out, and it's by Dr.
Harold Lazar.
Lazar? Okay, Dr. Lazar. So central message, which I like when they, on their commentaries, they always have a central message. So basically it's telling you what you're going to read after you, what you're going to come, the conclusion you're going to come to after you read this commentary.
Or they came to.
That they came to,
yeah.
Correct.
I might not come to the same
you
conclusion.
You might not. But he also says that, we need randomized multi-center studies. That's a theme with all of these, right? Okay. So the article that he's referring to is not Timmick. It's actually this article written by...
Don't even try to say it. These guys. Well, I would just point to their names and say these guys.
It says Lenoy. I think I can say that. I'll say the first one.
I think it's Lenoir.
Oh, maybe it is. Oh, gosh. All right, so these guys are going to have an article that's coming out, actually, I guess, a couple days ago. So he was. This was printed before it was published. publicly available in this same journal.
So it's ahead of print.
It's ahead of print, correct. So here's his introduction. Based on the results from Lanois and colleagues, they conclude that caution is warranted. So now this is the first study that is saying caution is warranted. The other ones have said we've had these good, or the other one said we had good results. Larger studies need to be done, but overall they had favorable things to say about Del-Nido being used, right? So caution is warranted in adopting, and the DNS is going to stand for Del-Nido solution. Del-Nido solution in aortic surgery requiring long ischemic times, and further studies are required to establish the exact role of the Del-Nido in complex cardiac surgeries. They also propose that if patients require longer than expected ischemic time, surgeons should switch from Del-Nido to multi-dose blood cardioplegia after 90 minutes of cross-clamp rather than attempting to redose with Del-Nido to avoid potential for lidocaine toxicity. And the author of this wholeheartedly agreed with it. Okay. This is also kind of long too, but I wanted to skim ahead and read with you. Patients undergoing surgical aortic valve replacement will have more complex anatomy, may require additional procedures, require longer cross clamps. There are currently no data to suggest that Del-Nido will provide adequate protection for these patients with right ventricular dysfunction and those with reduced ejection fractions who require longer cross clamps. Patients with multivessel coronary disease and those that have LV hypertrophy in which the distribution of cardioplegia is not uniform may also not be good candidates for Del-Nido. Okay. This one I had to clip out of kind of the middle of the paragraph, but also worth reading. Let's see. It is important to remember that the quality of the myocardial protection and not necessarily the time during which the myocardial protection is provided that will determine perioperative outcomes. The high-quality data obtained from a prospective multi-center trial will help determine whether or not Del-Nido is effective in protecting all types of patients undergoing all types of adult cardiac surgeries under all conditions. Until then, the jury is still out regarding Del-Nido in adult cardiac surgery. All right.
That's outstanding. That was outstanding, and we have. That was really, really, really good.
Great.
I enjoyed the heck out of that. And we got tremendous amount of commentary on it with somebody from outside of the United States who has similar concerns about the use of Del-Nido. They redose when they use it at 500 as a maintenance dose, or they just switch to blood at 1 to 4 intermittently. Okay. This place does about 1,200 cases a year. It's limited by surgeon's preference. Okay. He has similar reservations about antegrade only in patients with atherosclerotic heart disease or coronary artery disease, if you will. He understands that you can get away with antegrade only in pediatrics, and of course, getting retrograde in a congenital heart might be more challenging because of all the congenital, malformations. But of course, my view is they generally don't have coronary occlusive disease unless they have some kind of weird, aberrant coronary or something like that. Yeah. Did I lose something? Oh, I lost my mic. Sorry, I knocked it off. And he also points out that a lot of these places, and even here in the United States, he's talking about in his region, but in the United States, his or her region, the fellows are responsible for cannulation, which may make retrograde coronary sinus cannulation perhaps more challenging. Right. But even coronary sinus, and I think I covered all of your commentary. But and John, I want to bring you in on this because I know you do a lot of hearts there as well, not just ECMO. Even putting in a retrograde, if you put it in too deep and you don't protect that right coronary, that could be a big problem. So if you have somebody with a tight right, mid right coronary occlusion, and you give Del-Nido even if you try to give it, you're not going to get it into the, you're not going to distribute it into that right coronary area of distribution. And then if you put a retrograde in and you get it in too deep, if you're using intermittent, you can still find yourself in a lot of trouble. What's going on?
We can't hear you, I think.
Oh.
I think you didn't wear the right wardrobe.
Okay. Here, I'll just hold it. That's fine. I'm feeling very uncomfortable with your hands all around me. There, I'll just hold it like this. Is that better? So I think that that's that concern. So I have always appreciated people that do a graft and then put it down the graft past the occlusive disease to make sure that you're protecting that area. Because I've seen people not come off pump, and the only reason they didn't come off pump, I mean, I think everybody agreed in the room, was poor myocardial protection.
On the right side.
Yeah. Now, if you're doing a big aortic surgery and you need to protect the heart, you're going to do circ arrest or something like that, isolate it, whatever you're going to do. Further away? Okay. Okay.
Do you need to go to mic training class?
I'm getting wore out here.
Joe, no, you sound fine either way over here. So.
Okay.
Oh, okay,
Well,
good.
I don't know what their complaint is, but they're complaining. So what else? But that's how I feel about it. I think this person feels very similar to me.
I hadn't read
Tammy,
about
what say you?
Well, I have had a lot of experience with Del Nido, and I really liked it. I first started using it when we were doing minimally invasive.
Mitrals.
No, both.
Coronaries?
No, minimally invasive valves.
Valves, so
Yeah.
mitrals mostly, or aortic as well.
Aortic as well.
Okay.
And we had really good, experience with it.
But no coronary disease.
No coronary disease. But then we started moving into, well, let's do it when we also have a valve and a coronary. But again, it was usually limited coronary disease and also with an extremely, extremely fast surgeon.
Yes,
So,
Dr. Wynn.
Yes.
He
so,
was fast.
So you're not getting anywhere
Or he is
near.
fast.
Yeah, not getting anywhere near the redose time. And it never occurred to me that you could get lidocaine toxicity. It just hadn't occurred to me.
Yeah,
So-
you can.
Yeah.
You can. In fact, I know somebody who went to a dentist. I don't know them personally, but we got the patient because they couldn't get them out of pain, and they were on the table trying to drill, and they were holding him down, giving him Novocaine injections, and he went asystole.
Oh.
And it was actually toxicity from excessive use of the Novocaine.
Wow.
Yeah, it can happen.
Wow. What about you, John?
Well, I want to. I'm not experienced with lidocaine toxicity directly, but I wanted to. There's so much going on with what you presented here, Tammy, and I just wanted to see what the people are commenting. But let me just say a few things real quick. This whole evolution of Dr. Del Nido inventing and creating this wonderful myocardial protection solution was absolutely specifically and only for the pediatric and largely the infant population. And he has come out and said that every year at multiple, at least 1 or 2 meetings a year, where he can come out and stand up and say, I never designed this for adults. I don't believe it's meant for adults. The myocardium is completely different in adults, and this solution was tailored directly for the myocardium of small children, or at least young, very young children. And have you ever heard that saying when you're trying to do something in a situation somewhere and it just doesn't work and it just doesn't work and it just doesn't work, and somebody finally says, look, we're trying to put a square peg in a round hole over here. Well, and it doesn't work, right? Well, this is a case where somebody put a square peg in a round hole and it actually fit. Meaning we tried to use it on adults, and it actually seems to work most of the time.
Right.
It works great until all of a sudden it doesn't, and then it's largely a disaster. And it's not very common, but there is many, many anecdotal experiences where this has failed miserably. And one of the reasons why Dr. Del Nido comes out and talks about this, if you look at the article that you were talking about originally, not the commentary, the actual art, no, it's the commentary by Dr. Langer. You put up different segments there. But in the second paragraph, he says right here, irrespective of the formula of cardioplegia you use, the basic principles of myocardial protection remain constant. And he lists 3 or 4 there. But the first one he says is delivery to the entire heart.
Exactly.
Okay, this is the whole issue. If you have, what if 99% of our audience listening does cabbages, all the time at their institution? Why is a person coming to open heart surgery for a cabbage? Because they have coronary occlusions, generally greater than 80% and generally more than 2 or 3 vessels. If the blood is not getting past those blockages, the cardioplegia is going to have a hard time getting past those blockages. And in del nido cardioplegia, and in all cardioplegias, you need to have what it says right here by Dr. Langer's commentary, delivery of the cardioplegia to the entire heart. In the case of del nido cardioplegia, the reason why it's so risky to do coronaries, it's not so bad to do valves, aortic valves, and mitral valves in people with normal coronaries, as is the case with his pediatric population, is that the cardioplegia may not get past the blockages all that well. But in the case of del nido, because it's advertised as a one-time shot, don't need to do retrograde, which, by the way, helps compensate for tight blockages, because when you give it retrograde, now you're going back through the other side, and you get up to the muscle the other way. But del nido cardioplegia has the most powerful effect of keeping your EKG flatline, even though there may be parts of the muscle that are not well preserved. The del nido consultants, when you call the factory and you talk to the clinical experts out there in California, like I did, and you talk to them about their solution, if you ask them, should I be using this on adult coronaries, they will tell you no, you should not be. We prefer that you not do that. But people do it anyway. So here we are, flash forward, I don't know how many years this has been out, maybe 10 years now. And not only are people using it, a widespread adult population of surgeons are using it, at least to some extent.
And
I think,
sorry, please go ahead. No, forgive me. Go ahead.
And I think in the article, the commentary generated by 2 different aggressive commentaries to the article was, it almost seemed like the article was trying to say, look, we're getting criticism that we're doing these patients, and we just did a study and showed that 1 dose del nido cardioplegia is at least as good as, you notice how they,
as good as,
right. The conclusion was it's non-inferior to the blood cardioplegia patients. So get off our back, stop criticizing us. We can do 1 dose del nido cardioplegia on our adult cabbage patients, and it's at least as good as all of you guys criticizing us who are doing multi-dose blood cardioplegia. That's almost the tone there. And then the critics who come in and commentate later try to bring that forth in their criticism. So what do you guys think about all that?
Yeah, I think I think that all of your points are not only well stated, but well considered and well thought out, and I agree with everything that you said 100%.
I think you could sum up everything he said in one sentence. It works great until it doesn't.
Exactly. So exactly. And I think that if you're doing minimally invasive mitral valve surgery, for example, I don't have any issue at all with minimally invasive mitral, minimally invasive aortic, because you don't have concurrent coronary disease. You're there for one thing and everything else is wide open, and you know you're going to get this cardioplegia solution to all of the myocardium, the subendocardium, the septum, all these other parts of the heart.
Can I interrupt you for one second? I agree with that completely until I read that if you have to redose. So what if you get in trouble and it goes longer than what you think? Because I think if you're going to redose, I think you should redose with I think if you get in that kind of a situation and you're converting from minimally invasive to now, more invasive, or you have to open the chest and you have to redo it, whatever.
Yeah, what I meant by more invasive is you're now having to make your little incision bigger, and you're having to deal with that. I think at that point in time, bets off and you just go back to standard cardioplegia.
But I don't think people are doing that.
No, I don't think they are either, but that's their choice. I mean, if you're asking my opinion, I think my opinion, of course, is predicated on a lot of experience, not necessarily on data, objective data that I can point at and say, this is why I feel the way I do. So you have to consider that when you're, but I think that, again, from a commonsensical perspective, I would say at that point you convert to standard blood cardioplegia and you say, okay, we're going to have to get through this because it's a tremendous amount of volume that you're giving.
Yeah.
And, I know it doesn't seem to, as a single dose, contribute much to myocardial edema, but if you compare Del Nido with the volume, the sheer volume that you're giving, and that may be a hypertonic solution. I mean, there's a lot of other variables I recognize, but you compare that to microplege, which is giving very little, and they talk so much. If you talk to the company Quest, they have so much very strong data, published data, that's randomized and is definitely good data. Demonstrates that a lot of crystalloid in the heart causes a lot of myocardial edema. And so I think you can, to some degree, attenuate that depending on the tonicity of your solution and all of that kind of thing. But I think it gets very muddy, it gets very complicated. And from my, vantage point, look, we go on pump. We want to be out by noon with no balloon. Okay, that's the perfusion mantra, right? We want to get our case. We'll go on pump, come off pump, no balloon pump, no nothing else needed, no drips, no pressors, no nothing. Out of the room. And we're on the golf course, right? I don't even play golf, but I go to putt-putt. We want out, right? Do whatever we want to do. But, how much more time on a standard cabbage is really spent, and how much more complex is the field for the surgeon? I mean, I don't really see that. I've assisted. I've done all kinds of things up at the field. I've watched a lot of these things. I mean, I don't find it to be that cluttered.
Okay, well, I thought about this. So let's just say you use blood cardioplegia, you arrest the heart, and you have a doctor that is moderately fast, not the slowest, not the fastest.
So moderately fast versus being moderately slow.
Right. So I'm not
sure the differentiator to that.
Well, I mean, okay, so let's.
So they're kind of slow.
No, they're not slow,
No.
but they're not the speediest.
Okay, so a 10-minute anastomosis.
Sure.
Versus a 6-minute.
Or let's even say a 15-minute anastomosis,
Oof.
okay? Let's just say.
Okay, you're generous. That's slow.
Okay.
That's painful.
You're just spoiled because of all the great people we work for. But anyway, my point is, let's say you have to give a redose. You're doing standard blood cardioplegia. You give a redose.
4-to-1.
Right. You're going to give it at 15 minutes. Takes you about let's say you're given 200 or 250. Takes you about 2 minutes to get it in. Okay, so that's 2 minutes. Now they do their next anastomosis, and we're doing 4 vessels, let's say. And so then you're going to give another dose, and then you're going to give another dose. So now we've added 6 minutes.
Yeah, so what?
Yeah, that's my point.
So what?
6 minutes.
Right.
Even if you did 10 anastomosis, I mean, it's still not that much time.
I totally agree with you.
Compared to, if
the stress of having to hurry because we're running out of time and we're going to go past the time, and should we redose, should we not redose? I can assure you the stress factor for that is not worth 6 minutes.
Yeah.
For me,
I mean, because
even 10 minutes.
I really started thinking
minutes,
about it after reading these.
We're there for 4 to 6 hours
and I love
doing a procedure.
I love Del Nido. I'm able to chart. I'm like getting all my things done. I'm not having to watch the timer. So I might have a different opinion now.
I think the people
that like Del
Nido, I think the people that benefit from Del Nido the most is not the surgeon, it's the perfusionist.
Yeah.
Actually. Because it's one shot and you don't have to worry about all the things that you had to worry about before with, timers and everything that's going on. Actually, I'm not sure it adds any time to the surgery. If you notice, most surgeons, when they get done with the anastomosis, they give you're giving retrograde while they're playing with the next vein and they're pressurizing it and make sure it doesn't leak. They're finding stuff to do. They're not standing there doing nothing while you're giving that dose. And then when they're ready and you're done to go, they go right on.
Right. And they usually have an assistant that can take the octopus and put it on the coronary and give it, and they're, they may look at it and twist it and look at it and see how it looks, and mark it. They do all kinds of things.
Yeah,
I mean, I've seen so many
different
things.
Part of the thing about giving cardioplegia down the vein, they're checking to see that their anastomosis doesn't leak.
Right. It's double duty there, for sure.
Right.
Yeah.
Exactly. So we're going to do 2 more questions, and then we have to go to the journal, to the
Knowledge Nuggets.
Knowledge Nuggets, because I have a conference call at 7:15. So I'm going to have to excuse myself if we're not done by then. So we're going to try to finish tonight at least somewhat on time. But this question is directly to you, John. John, would your opinion change if delivery was given in a similar manner to blood cardioplegia, both antegrade and retrograde?
Yes.
Okay.
But, I mean, you have to consider the lidocaine toxicity. I think that would be a wonderful thing because, one of the things about multi-dosing is that, let's say what I just said, you have a tight blockage. Well, now you have a graft past it. You could give down the graft, or you just have multiple opportunities to get some cardioplegia past that blockage. You just don't have one chance at it. And if you're giving retrograde, you now have another avenue where you may get good myocardial preservation to an area that's tightly blocked. And believe me, there's plenty of failures with multi-dose and antegrade and retrograde, but I think it's probably pretty minute if you're thorough with what you're doing.
Absolutely. And in fact, it's supposed to be at 7:15, but they're 7:15 Central Time, but they're doing it 7:15 Eastern Time. So
you're late.
I'm gonna have to excuse myself. I'm gonna have to go out there, do this conference call. John, I'm gonna leave you and Tammy to do Knowledge Nuggets. If you guys will please forgive me, it probably goes much more smoothly without me. But I do want to say, Amit says, very interesting discussion to both of you. Dr. Del Nido also cools all of his peds patients to 32 degrees, which also helps with keeping the heart arrested. So he pointed out, but I think we do that with our coronary. I mean, some people do stay warm, but I think we drift. We go maybe
drift.
34. We drift.
But the point is well taken, is that drifting and going to 32 are not the same thing.
Correct.
By the time I get to 32, I'm already going to be warming,
Very good point. So if you all will please excuse me, I'm going to turn this over to the highly qualified and capable Tammy Sparacino and John Ingram. David, if you could just cut me out of the picture and they can do the Knowledge Nuggets, and I will do the conference call. Hopefully I can come back. I'm sorry. Thank you.
Yeah, no problem.
No problem. Turn your mic off, though.
We will
hold the
fort down, as they say.
That's better, because there's probably going to be a lot of curse words.
Ready to do it? I'll play the intro.
Okay, we're ready for Journal Club. Let's cue the intro. Knowledge Nuggets. Let's cue the intro.
Close out and tell everybody, do the thing.
Do the thing? I can do the thing. And we're back. Okay, John, I turn it over to you.
All right. So if you're able to see the questions on Joe's computer, we won't even miss them if people call in with questions. So there you go. Okay. So Tammy, we are on episode number 3.
All right.
Believe it already, number 3.
Yep.
And today is February 25th, 2021, and it is John Ingram Knowledge Nuggets. And of course, as always, I will have no disclosures on this today. And so our Knowledge Nuggets motto, and the reason why we call it a nugget, is because we're going to try to make this concise, and our motto is spend a little time and expand your mind. So this week's topic, antifibrinolytics. We all know them, we all use them. What do we do with them, right? So we have 2 largely that we see out there that we use: tranexamic acid TXA, or aminocaproic acid, also known as Amicar. So our format of Knowledge Nuggets is a different topic each week. If anybody's just tuning in, the purpose is that you can take home something from this presentation that can be better conditioned tomorrow. And we're going to label those slides with, you see a gold nugget up in the corner like that, a shiny gold nugget. That'll be a take-home slide that you can do a screenshot or take a snap with your phone and take it to work tomorrow, and you'll have a smarter experience tomorrow at work. So it's just a short segment, 12, 15 minutes. Then we have a little thing at the end that we call the gem of the week. That's a surprise little feature that we have. You'll see about that in a minute. Then we do the panel discussions, which is just about 15 minutes or so after that. And if any of you guys have questions, comments, suggestions, please email me at john.ingram@perfweb.us, and I will answer every email that I get through that email. Okay, so what are antifibrinolytics? Tranexamic acid, TXA, and its actual official name is epsilon aminocaproic acid, but most people call it aminocaproic acid, also known as Amicar. So we're basically talking about these two drugs. So here's a golden nugget slide if you want to know what they are and a way to define them if you're not sure. They're a class of medication that are inhibitors of fibrinolysis, hence the word antifibrinolysis. Examples include aminocaproic acid or Amicar, tranexamic acid, and a protamine, which once upon a time was very widely used here in the U.S., but has since been banned by the FDA and is only used now in Canada and Europe. And by the way, it is a wonderful working drug, but we can talk about that on another day. And these are a synthetic lysine amino acid derivative. We'll talk about why that's important. And what it does, it interferes with the formation of plasmin from its precursor plasminogen. In other words, it's going to disrupt the ability of plasminogen to convert to plasmin. And this transition, the conversion of plasminogen to plasmin, takes place actually right on the surface of the fibrin. So just looking real quick at our coagulation cascade, and this is the old school coagulation cascade, but that's not important for this particular topic. So you see, you can start with or intrinsic or intrinsic, but what I want you to focus on is what's in red. So once you get to the common pathway and you get down there to the bottom and you see where fibrinogen forms a fibrin clot. That's what I want you to focus on for this purpose of this talk today, okay? And see there, that's what I want you to focus on, okay? So we're going to talk about the fibrin formation, and this is where antifibrinolysis, these two drugs, come together, come into play, okay? So here we go. Fibrinogen turns into fibrin, and it's this fibrin that forms a stable fibrin clot. Okay, so let's just look at real quick the formation of a clot. You basically have the top up there, a vessel, a blood vessel that's been traumatized, it's been ruptured, and it's been breached, and the blood is leaking out of that vessel. You initially have some vasoconstriction, but basically what you have in the second one is that you have platelets that immediately begin to try to plug this hole. Well, that's fine and good, but they are not going to stay in place very long, those platelets, unless you have the bottom there of fibrin webbing, a fibrin network, like a net, but a fibrin meshwork that has to form around this glob of platelets in order to keep it in place and to keep that clot stable. Okay? So there you go. That's what I want to focus on, is that fibrin mesh work that you see there that comes in and webs all those platelets together and makes it a stable clot. That's what we're going to focus on here today. So now, when you look briefly at the time frame of healing, you have wound that occurs, and the clot there forms basically right away to immediately control the bleeding. And then what you have is in day 4 through 2 weeks, this is the time it's going to take for a new blood vessel to heal. So that clot has to stay in place for days to weeks sometimes. And what you have here is that your fibrin clot forms there in black, but then what immediately starts to happen is that the body knows that that clot needs to slowly degrade and slowly dissolve, but in concert with the vessel wall healing itself and coming back together and forming a closed vessel again in a permanent state. That clot is just a temporary plug to fill the gap while the vessel can heal. Well, that clot is going to slowly dissolve, usually over several days to a couple weeks, and that slow dissolving process is something called degradation, degradation, which occurs via plasminogen converting to plasmin. One of the ways you can measure your fiber degradation products is through something called D-dimers, and you people have probably heard of D-dimers in your studies. So let's look at the fibrinolytic cascade, and this starts with plasminogen. So plasmin, which is formed from plasminogen, is a serine protease that acts to dissolve fibrin. Serine protease being an enzyme, it acts to dissolve that fibrin meshwork I was talking about. And what it does, it binds to these lysine receptor sites on the surfaces of the clot. Plasminogen gets converted into active plasmin by the enzymes tissue plasminin activator. All of you have heard of TPA. It's a clot-busting drug that we use. And you've heard of urokinase. It's also a clot-busting drug. But these are naturally occurring enzymes that actively convert plasminogen into plasmin and help dissolve your clot, which is why plasminogen, TPA, and urokinase are clot-dissolving agents. So this is going to occur somewhere around 4 days to 2 weeks to slowly dissolve a clot. That's the plasminogen and fibrinolytic cascade. It's a very slow process. So here's a take-home slide for you. So how do these, what is the clinical pharmacology and the mechanism of action of these antifibrinolytics? As I said, they bind to the lysine receptor sites of the plasmin, but they saturate these binding sites, therefore displacing the plasminogen from binding to the surface of the fibrin. They block the binding sites of the plasminogen and thus stop plasmin from forming. Therefore, they prevent plasmin from dissolving the fibrin matrix, which is holding the clot together. The pharmacokinetics are fairly simple. These drugs are largely eliminated through the urine and diuresis, and the half-life is approximately 2 hours. And that's true with both these drugs, by the way. So indications for use. There's a golden nugget. Take-home slide if you guys are wanting to take home something with you you can talk about tomorrow. It's indicated in patients with hemophilia for short-term, usually 2 to 8 days, to reduce an acute hemorrhage episode they may be having. But it enhances hemostasis in cases of, this is important, in cases of fibrinolytic bleeding. It's not just used in any type of bleeding abnormality. It has to be, the bleeding needs to be caused by fibrinolysis. So this fibrinolytic bleeding can be due to surgical complications like we see following heart surgery, also in portacable shunts, but there are also some hematological disorders that you can use antifibrinolytics as, and we're not going to dive into these, but aplastic anemia, abruptio paciente, hepatic cirrhosis, and neoplastic diseases such as carcinoma of the prostate, lung, stomach, and cervix. And these particular disorders you can read up on basically have a large component of fibrinolysis going on with them. So contraindications, when there is evidence of intravascular clotting, in other words, when you have intravascular clotting, you do not want to have fibrinolysis, antifibrinolytic drug, because that's going to aggravate the situation, right? It's going to disallow you to dissolve those clots. You would not use it in patients with subarachnoid hemorrhage due to risk of cerebral edema and cerebral infarction. And you cannot use it in DIC without concomitant heparin. Same thing it's saying in item number 1 there. So we need to know if we're in DIC or if we're in just fibrinolysis. We're going to talk about that here in a second. So this is exactly what you need to do. If your patient is bleeding and you're not sure if the patient is in DIC or fibrinolysis, you run what most labs call a DIC panel. And it consists of a multitude of tests, but here's 3 of them I'm going to point out to you. And one of them is you run a platelet count. And a platelet count is going to be greatly decreased in DIC, but it'll be normal in primary fibrinolysis. That's one difference. difference. In the lab, they have something called a protamine paracoagulation test, which is kind of interesting. They actually take citrated plasma and they drop a little bit of protamine into this plasma, and this will form a precipitate. If it's in DIC, it'll be positive, but it won't precipitate out if it's in primary fibrinolysis. And then there's something called a euglobulin clot lysis test, which will be abnormally, I believe, abnormally high in fibrinolysis, but it'll be normal in DIC. So we can differentiate the patient's problem between DIC and fibrinolysis, and this is important so you can use your antifibrinolytic drugs in fibrinolysis, but not in DIC. So dosage for Amicard, just for your reference, is 4 to 5 grams injection, usually mixed in 250 milliliters over 60 minutes. Then it's followed by an infusion of about 1 gram per hour. You can give it continuously for about 8 hours or until the bleeding has been come under control. And again, the half-life of the drug is about 2 hours. In tranexamic acid, TXA, it's a dose of 10 milligrams per kilogram. Usually you can give it 3 to 4 times a day intravenously for also 2 to 8 days. Half-life is also 2 hours. So some adverse reactions that you can look for, there's a bunch, but the most common ones, you can have nausea, vomiting, diarrhea. You can have allergic dermatitis. This has to do with, by the way, if you give the infusion too quickly, and I said on previous slides the rate you should give it, you can actually have phlebitis and be very irritating at the site of administration. These drugs can also cause some confusion and delirium. You can also have some hypotension, and you can also have paradoxic thromboembolic events. Can also occur. Here's an also take-home slide for the conclusion. To bring it all together, you can have inhibition of fibrinolysis. So the hemostatic system helps maintain circulation after a vascular injury, whether it's traumatic or surgical in nature. Major surgery or trauma may result in severe blood loss and present challenges to the coagulation system, right? We have this coagulation system that's set in motion. Remember, the fibrinolytic system is part of the coagulation system, slowly beginning to dissolve these clots. If that begins to spin out of control and becomes hyperfibrinolytic, we may have an application for antifibrinolytics. So part of the response to surgery and trauma is stimulation of fibrinolysis, which could become pathological hyperfibrinolysis in some cases. So antifibrinolytic agents reduce blood loss in patients with both normal and exaggerated fibrinolytic states, and they do so with pretty minimal risk of postoperative complications. The complications we see with these drugs are actually nicely and comfortably pretty minimal. So now we're ready for the gem of the week. And as you guys know, this could be anything from a perfusion trivia question or a medical trivia question. You never know what you're going to get. Maybe we'll discuss how to have an excellent virtual interview. Maybe we'll discuss, as we did in week 1, a nice career opportunity or a job offer that's going on out there on the web. How about a product recall, something in the perfusion news? We might bring something to you 1 week on that. Something happening in perfusion, celebrating Perfusion Week with a scholarship or a notable perfusionist that's retiring. Maybe we'll just bring in a famous quote and discuss something along those lines, or we might even talk about an upcoming conference. It could be anything, and every week it will be a surprise. So what do we have this week? This week's episode's Gem of the Week is going to be the top 10 qualities of highly successful people. Okay. And I really like this one. So why do we want to talk about this? Well, you know, in life, whatever you set out to do, whatever it is, even if you're a stay-at-home mom or housewife, you want to be successful at it. You want to be a good one, right? So in life, no one sets out to be a failure. So what? Well, in today's society is rather obsessed with success and achievement. And in a lot of things, people, you hear buzzwords and things like failure is not an option. And you could probably come up with 2 or 3 other ones where, you know, failure is just not something that we're going to allow to happen, and things along those lines. You hear those phrases and buzzwords in our society a lot. So People who live their lives and just do what most people do basically get what most people get. In other words, if you strive and look at your life and perform to be average, you'll probably end up accomplishing an average amount of success. So how? How is this going to happen? If you desire success, you have to cultivate yourself, just as you would cultivate a garden or something that you want to grow into. So, Tammy and all of our listeners, and if Joe was here, this was just perfect for Joe. So we're going to go through real quickly the 10 qualities of highly successful people, and I want you to grade yourself. And you can ask yourself, do you have these qualities? But in large portion, most of us are going to believe that we have most of these qualities. So I would actually say, why don't you grade yourself? Give yourself, yes, I have an A in this particular attribute, or maybe I do it so-so, and give yourself maybe a C, and maybe say, I really don't have it at all, and maybe give yourself, you know, an F. And just grade yourself and be a little critical, because it's easy to be not critical enough in these, and really ask yourself, do I have these qualities, and can I improve, really is the point on any of these. So let's take a look at some of these. So drive. Successful people work harder than most people, and they get things done. And people who have drive pride themselves on seeing things getting completed. They drive themselves with purpose. Number 2, self-reliance. This is very important. People lack this a lot. But highly successful people take responsibility for their actions. When they make a mistake or fail or do something they shouldn't have done, they largely take responsibility for their actions, and they be accountable for their actions. Willpower. See things through and don't procrastinate. So in other words, stay focused on your goals and be consistent. Don't set out to do something and you're going to accomplish something, and 2 or 3 weeks later you kind of be like, well, you know, I'm really not, and you kind of get lazy and you don't stay focused. You're not going to get very far like that. So you have to see things through and have willpower on your goals. Highly successful people have patience. A lot of times you think they don't, but really highly successful people, they learn to be patient, and more importantly, they learn to exercise patience with people around them, because a lot of times, you know, people around you, you have all this experience and you're doing all these type of things, but you were new once too, and the people around you who you just hired or who are new are going to need you to require you to have some patience and realize in your goals there's going to be some failures and some setbacks. Don't let that discourage you. Forge on. Number 5, highly successful people have integrity. And C.S. Lewis, the famous author, once said, integrity is doing the right thing even when no one is watching. In other words, doing the right thing even though no one will ever know if you really did the right thing or not, because you're the only one there to witness what is going on. And integrity, though, it creates character and defines who you are. So you ought to take pride in that. Number 6 is you have to have passion. If you want to succeed, it's your passion that will get you there. Highly successful people always have passion for what they want to accomplish. Number 7 is connect with others, or more broadly put, relate to other people. Learn to relate to others. It makes everything you do more effective, and it has a bigger impact with the people around you. You know, try to relate to other people. Put yourself in their shoes. Understand where they're coming from. Maybe relate to the experiences and backgrounds that they have. They'll appreciate you more, and what you do for and with those people will be far more effective. So, in other words, life is, you know, 10% experience, but 90% of how you respond to that situation or to that experience. Number 8 would be optimism. Highly successful people are largely pretty optimistic because they're envisioning a bigger and better future. They have a goal in mind to improve something. So it's necessary to believe that the future can be better, and it's empowering, by the way, to take responsibility for making life better, not only for yourself, but for those around you. And if you have that attitude, I think you will feel empowered. Number 9 is have self-confidence. And this is a slippery slope to some extent, right? Because you do need to have self-confidence in your knowledge, but you must be humble, remembering there is far more that you do not know than what you do know. Self-confidence is productive while overconfidence is egotistical and destructive to your success. And number 10 is going to be communication. This may be at the top of the list. Probably could be argued that this could be the most important one if you had to pick one. At the core of all successful people is good communication. Good communication generates trust in those around you, and it generates respect from all of those around you. Okay? So, that'd be interesting to see what people have to say about that. And then, as I said earlier, guys who are listening, if you're listening to this live or if you're listening to this anytime in the future, email me with comments and questions about anything that we've covered and suggestions for future topics that you'd like to see in an upcoming show. And I do and will respond to every person who sends me an email to that email address there at the top. All right, so thank you guys for listening. Our panel discussion is going to be what we talked about, antifibrinolytics and the top 10 qualities of highly successful people.
Great. That was
How'd you
really
like that,
good. I loved it. Oh, we have a phone call. Okay, let's go live with the phone call. Hi, you're on the air. Did we have someone? Oh, well, they disconnected. If we lost you, please call back. John, what a great presentation. And actually, I have I just came up with one question. I mean, pretty familiar with using the antifibrinolytics. We mostly use Amicar, but we do occasionally use TXA. What I wanted to know, because I found when I was just at one facility for a long time in my career, it was standard. We always used Amicar, and it was always in a certain way. But now that I'm out and at a lot more facilities, I do see variability. So I wondered, what are you dosing when you are going on pump with these, for instance, with Amicar? How are you determining what your pump dose is?
Well, in the places where I worked and in my travels, you know, I found three things would happen. One, people don't prime with it, which was kind of the least of all of them, believe it or not. And largely I saw people prime with 5 grams. And I did work at a place where they put 10 grams of Amicar in their prime. But I think in addition to that, anesthesia was always giving, I think, 5 grams also.
Okay.
And I'm trying to think back in the place that gave 10 grams in the prime. I'm almost wondering if that was a shortcut around anesthesia not giving their 5 grams. But basically that is largely what I've experienced is either 5 or 10 gram in the prime.
And what about for TXA? What are you seeing? What are you putting in your pump prime for that?
Just the same. What comes in one vial? Is it? I've used it one time, so it's been a while. I don't remember but I remember putting in. I think it was 1 vial. But the only time that we used TXA was when the Amicar in the pharmacy couldn't get Amicar.
Yeah. Yeah, we have one location that and an anesthesiologist that likes the TXA, and I think that came from when Amicar was on back order and we had to kind of make some adaptations, but they've just stuck with it. But we give a very small amount of that. I'm not sure exactly what anesthesia is giving on their end, but we are giving 1 cc, which turns out to be 1 milligram into the prime. So I was just curious about that. As far as the Amicar, I had the hospital that I worked at prior to working for ATT. I was there a very long time, and it was very standard. And we had we always gave 10 in the prime. Anesthesia always gave 10, and then they did a 10 bolus, 10 in the prime, and then 10 through a drip. So it was always 10, 10, and 10. So I had never seen it where people were only giving 5 grams. And I was just kind of curious. More and more I'm seeing that, and I just wondered if that was something that was more common, and I just hadn't seen it before. So it sounds like the 5 grams is probably more common. Would you say so?
It seems like, I think it started off that way. I wouldn't be surprised if people have sort of upped their dosages over the years because they saw success with it. And, you know, really the half-life is only 2 hours.
Right.
But, you know, if you read the manufacturer's insert, which, by the way, if anyone wants to know, a lot of what I just presented I go to the manufacturer's insert both for Amicar and TXA,
Mm-hmm.
and there's no indication there for putting it in the prime.
No, I know. I've looked that
they-
up before when I tried to answer this question on my own. Right, it's not. There's no indication for it there. So that's really the only question I came up with. This was just really great. I loved it so much, and the gem of the week was fantastic. I actually want to talk a little bit about that, if you don't mind.
Yeah, how did you do on that? I bet you did pretty well.
I think I did okay. There were ones that I know that that come to me more naturally, that I don't really have to work as hard at, and ones that don't come to me naturally that I definitely need to work on. So you kind of thought communication was probably the most important if we had to rate them. And I tend to agree with you, but I think a close second would probably be connecting with others. And I think that's where a lot of people, that's one that a lot of people overlook, because we like to connect with people that are like us and think like us and do things like us. But I think the real challenge is connecting with people who aren't like you, because we're probably going to find more people who aren't like ourselves than we find that are like ourselves. And making those connections with people that you wouldn't normally connect with can make you highly successful, because you're often going to get new perspectives, new ideas from people who think differently than you. So I just wanted to kind of bring that up. I think number 7, connecting with others, is also very, very important.
If you've ever noticed, if you've worked in a place where everybody seems to like the supervisor, and if you ever notice, you went in at one point and talked about a situation with the supervisor, and the supervisor connected with you. You had a great conversation. Next day, somebody completely different than you, maybe it's just their likes and dislikes in life. Maybe they're a male. Maybe they're everything about them can be different. Sits in front of that same supervisor's desk, and that supervisor relates to that person in exactly as good of a level as they related to you. So if you have a supervisor that nobody likes, a lot of times that's the opposite. They don't seem to relate very well, but just with 1 or 2 people, and that's even worse, because now it's perceived that that person has favorites among the employees. So highly successful people who basically end up having a lot of people work for them or work around them, people like that and gravitate to those people because they relate to everyone they can possibly relate to in a positive way.
Well, and don't you think too that usually if you can connect with others, and this is kind of a self-serving way to look at it, but connecting with people, you can often get them, if you're a supervisor, for example, to work better for you, do the things you ask of them. But as an individual, you can usually get things done that you want to get done if you know how to connect with them. You know, children would be a perfect example. I mean, if you have multiple children or even multiple friends, you know effective ways to communicate with them, and with children especially. You know, if I communicate this certain way, I can get them to do what I want to do with the least amount of trouble. But the other child, that way doesn't work at all, so you learn a different maneuver to be able to accomplish what you need to. And I think it's the same with any kind of project or whatever it is you're trying to get done, is figuring out how to motivate people in a way that you're going to be able to be successful and get the things done that you need to get done.
Right. I mean, a leader is still only one person, and only one person can physically do so much. That person needs to surround him or herself with a lot of good, qualified, but motivated people that want to work or work with or under that supervisor. They like working for that person. They want to perform well for that person. And if you've ever, I can give you a quick example people have probably seen. If you've ever watched sports every now and then you'll hear a player in an interview say, "We really love playing for this coach."
Yeah.
You don't hear it very often, but I think most of them do love playing for their coach, but they don't say it. But every now and then you'll hear a player say that. We really loved, or when a coach is leaving, maybe or retiring, they'll say, "We loved playing for Coach so-and-so." And that tells you a lot about how people who, that coach is way past his prime. He can't get out there and play a lick. He needs those young players to be motivated, and want to do what he's asking them to do, you know, he or she in some case. So there's a kind of a clear example that we see in everyday life for people just to see right on the television, despite whatever you're doing in other parts of your life.
Yeah, agreed. Well, I think that's everything I have. You have any closing thoughts, John?
No, I think it was great. I actually also have an 8 o'clock appointment, which right now it's 8 o'clock.
Oh, okay. Well, let's wrap this up.
Too. So if we're close to ending, it's fine. If not, we can run a little late.
No, I think we're all good, and we can end right here. So thanks everyone for joining us, and I think it was a great show. John, once again, very thorough and concise information, and I really enjoyed your presentation.
And I enjoyed yours as well. It was fabulous, really fabulous, lovely. Good topic.
All right, well, everyone, thank you. Have a wonderful evening, and coming up next, I need a little help here. I wasn't prepared. March 10th will be our next Journal Club and Knowledge Nuggets, and that'll be on a Wednesday at 9 a.m. Central Time. And so we hope you can join us then. And what's the topic going to be, David? Sorry.
I think mine is, if I'm not mistaken, oxygen dissociation curve, I believe.
Okay, oxygen dissociation curve will be the knowledge nuggets, and then the Journal Club will be Ecmo cannulation for post-cardiogenic shock. All right.
Nice, okay.
All right. All right, I think that's it. Thanks, everyone. Have a wonderful evening.
Thank you.